This is Dr. B. Sasikala, reader in the Department of Oral Maxillofacial Surgery at SRM Dental College and Hospital, Ramapuram. Will be delivering a talk on temporomandibular joint arthrocentesis. The word arthro refers to a joint, while centesis means a surgical puncture made to remove fluid. So together, arthrocentesis is a procedure that involves puncturing a joint to withdraw fluid. Arthrocentesis is traditionally defined as a procedure in which the fluid in the joint cavity is aspirated in the needle and the therapeutic substance is injected. This is a minimally invasive technique, which means it does not require large incision or major surgery, making it safer and quicker for recovery. A key part of the procedure involves lavage of the superior joint compartment, where fluid is used to flush out the upper part of the joint to help reduce inflammation or remove debris. Importantly, this entire process is done through closed joint irrigation, meaning the joint is cleaned internally without opening it up, helping to minimize the risk of infection and speed up healing. During the 1960s, arthrocentesis, particularly of large joints like the knee, emerged as an accepted and effective medical treatment. As the procedure gained recognition, physicians began to explore and refine a range of techniques aimed at breaking down and flushing out inflammatory substance or debris from the other joints. These advancements extended the application of such methods to additional joints, including the hip, shoulder, ankle, and wrist, broadening the therapeutic potential of joint interventions across the body. Murakami was the first to introduce a technique for TMJ arthrocentesis that involved using pumping irrigation along the hydraulic pressure to flush out the upper joint cavity. After the irrigation, the jaw would be gently manipulated to help improve joint movement. Later on, Nitzen and colleagues improved upon this method by using two needles instead of just one. This modification allowed for a more thorough flushing or lavage of the joint and also enabled both aspiration and injection during the procedure. For this technique, the insertion points for the needles are carefully marked in the skin. These reference points are based on the approach described by McCain and colleagues for TMJ arthroscopy, specifically using a posterolateral route to access the upper joint space. Indications for arthrocentesis include anterior disc displacement without reduction. This means the disc in the joint is displaced anteriorly and cannot return to its normal position, often leading to limited mouth opening and pain. Symptomatic anterior disc displacement with reduction. In this case, the disc is displaced anteriorly but moves back during jaw movement. If it causes pain or joint noises, arthrocentesis may help. Anchor disc phenomenon. This refers to a condition where the disc is stuck or adherent to the joint surfaces, restricting joint movement and causing discomfort. Palliative treatment for acute episodes of degenerative or rheumatoid arthritis. Arthrocentesis can be used to relieve pain and inflammation during flare-ups of arthritis affecting the jaw joint. Hemarthrosis following trauma. If there is a bleeding into the joint after an injury, this procedure can help by flushing out the blood to prevent damage and reduce pain. Contraindications for arthrocentesis. Psychiatric conditions. Patients with psychiatric disorders may not cooperate or tolerate the procedure safely. Fibrous or bony ankylosis. When the joint is fused, access to the joint space is restricted, making the procedure ineffective. History of multiple surgeries on the TMJ. Repeated surgical interventions may alter the anatomy and reduce the success or safety of arthrocentesis. Regional tumor. Local infection near the joint. Performing arthrocentesis in the presence of nearby infection can worsen the condition or spread infection into the joint. How does arthrocentesis work? It forces the flexible disc from the fossa, flushes out degraded particles and inflammatory substances, reduces pressure inside the joint, especially when it is inflamed. When 50 ml of Linger solutions is used, it will help to eliminate the catabolites present in the synovial fluid. Using 100 ml of fluid helps to remove broken down blood components and harmful enzymes. Washing with 300 to 400 ml helps to clear out pain-causing substances like bradykinin, interleukin-6 and other proteins. TMJ arthrocentesis can be performed using either a single or double puncture method. Nitzen et al. Described the traditional double puncture technique, which involves inserting two needles into the upper joint space. This method allows for extensive lavage aspiration, and injection of the joint. The single puncture method is further divided into two types. Type 1 is the single needle cannula technique where both inflow and outflow occur through the same cannula and lumen. Type 2 is the double needle or dual needle cannula technique where inflow and outflow are channeled through the same cannula system but with separate ports and lumens. In the technique outlined by Nitson et al., a line is drawn from the lateral canthus to the most posterior and central point on the tragus. The posterior entry point is located along this line 10 mm from the center of the tragus and 2 mm below the line. The anterior entry point is 10 mm further along the line and 10 mm below it. This is point B, marking the site of the TMJ eminence. Laskin et al. Suggested that while access to the anterior recess is unnecessary, the posterior needle placement should follow Nitson's approach, while the anterior needle should be placed 3 to 4 mm ahead of the posterior needle, making the procedure easier to perform. This is point D. Alkan et al. Proposed an alternative where the first needle is placed at Nitson's specified point and the second is inserted 7 mm anterior and 2 mm inferior along the same line. The needle placement is adjusted slightly behind and parallel to the first until bony contact is made. This is point C. Outflow is easier to achieve when the second needle is inserted behind the first in the widest part of the upper joint compartment. The double puncture technique begins by marking the canthotracheal line with points A and B as previously described. An auriculotemporal nerve block is administered. An 18 gauge needle is then inserted at both point A and point B. Lavage is carried out when the lingus lactate being introduced through one needle and the outflow observed through the other needle. Platelet-rich fibrin was administered at the conclusion of the procedure. Complications of TMJ arthrocentesis. Facial nerve injury. The facial nerve can be damaged during the procedure as it runs close to the temporomandibular joint. This could result in facial weakness or paralysis on the affected side. Trigeminal nerve deficit. Injury to the fifth cranial nerve could occur, potentially leading to numbness or pain in the area it innervates. Aortic injury. The procedure may injure the ear structures, leading to discomfort, hearing loss, or other related complications. Edema from fluid leakage. If lavage fluid leaks into the tissues surrounding the joint, it can cause swelling in the extra-auricular space. Needle breakage. Although rare, the needle could break during the procedure. Acute joint inflammation. The procedure may trigger an inflammatory response in the joint which could worsen the symptoms and cause temporary pain and swelling. Allergic reaction. Patient may have an allergic reaction to lavage fluid or medications used during the procedure, causing symptoms like rash, swelling, or difficulty breathing. Intracranial perforation. Though extremely rare, there is a risk that needle could puncture the deeper structures, potentially leading to an intracranial injury. Jaw trauma from repeated punctures. Multiple attempts to access the joint could cause trauma to the joint. Severe vertigo without hearing loss. Some patients may experience intense dizziness after the procedure. Preauricular hematoma, extradural hematoma. Superficial temporal artery injury. The artery that runs near the TMJ could be damaged, potentially leading to aneurysm. Arteriovenous fistula and joint bleeding. In rare cases, the direct connection between an artery and a vein could form, leading to abnormal blood flow and possible joint bleeding. These complications emphasize the need for careful technique and experience in performing TMJ arthrocentesis to minimize risk and ensure patient safety.